Good morning, everyone. Thank you for giving me this opportunity. Now I'm going to present my topic is pupillary block post-complicated cataract surgery, two different clinical scenario. Pseudophakic pupillary block. The implanted intraocular lens is partially or wholly involved in the obstructions of the aqueous flow through the pupil. It develops in the days, week, month, or year after surgery. It may be due to the mechanical closure of the pupil by the IOL optic or post-op inflammation causing the formation of posterior synechia and adhesion between the pupillary margin and anterior plane. I will plane. Now I'm going to my case scenario first. 66-year-old man on post of 1 week, complicated status post complicated cataract surgery, presented with the pain and dimness of vision. Vision was 636, IOP was 32 millimeter of mercury. On slit lamp examination, AC was very shallow with iris cloth lens in situ with non-patent PI. This is the picture. This is the AC was very shallow. So we diagnosed mostly probable pupillary block due to the non-patent PI. We did left YAC PI. Immediately post PI, AC was deepened. IOP became 16 millimeter of mercury. This is the picture. At the 1 month, vision became 6.6. IOP became 18 millimeter of mercury without AGM. This is the picture of 1 month. AC became deepened. This is the AIOCMT3 which is showing the PI was patent. AC became deepened. My another case scenario. This is 69-year-old man post of 1 day, status post complicated cataract surgery. IOL was in sulcus. On slit lamp examination, AC was very shallow, VH grade 1. We can see hazily vitreous block blocking the pupil. Digitally, it was very hard. NCT was 42 millimeter of mercury. We diagnosed probable case of status post complicated cataract surgery with IOL in sulcus. We did multiple PI. AC became deepened. Post at the 1 week later, vision became 6.9, AC became deep, patent PI was there, NCT was 77. We can see the vitreous blob at the pupillary margin, which is not touching the endothelium. At the 1 month, the same finding was there, fundus was not within normal limit. This is the picture of anterior segment. This is the AIOCMT, which is showing the vitreous blob at the pupillary margin with PI, which is not touching the endothelium. We took for this vitreous blob for retina consultation because vision was 6.6. So they keep in close observation patient because there no traction was there. So just one study that telling that intraocular lens designed solely for the capsular bag, it should not be placed in the ciliary sulcus. It may cause the pigment dispersion, iris translumination defect, dysphotopsia, elevated intraocular pressure, intraocular hemorrhage, and cystoid macular edema. So in case of vitreous disturbance in sulcus, place single piece acrylic IOL PI should be done. Due to the risk of dissenting and posterior iris displacement, sulcus can precipitate relative pupillary block and chronic angle closure. So I'm going to tell my case scenario another. The 53-year-old male, history of 2 days post left YAC cap. Vision became 1/60. AT was 52 millimeter mercury. Before YAC cap, vision was 6.9 parts. IOP was 21 millimeter mercury. On slit lamp examination, corneal edema, bit dilated, fixed pupil. AC was very shallow, but patient has inferior mild discented PCIOL. We given the oral glycerol, acetazolamide, topical AGM. Then we may be diagnosed pupillary block glaucoma status post YAC cap. So we did the left YAC, multiple YAC PI was done. After 2 days, vision became 6/6. AT was 6 millimeter mercury with AGM. On slit lamp examination, cornea clear, AC was formed. Vitreous was present, but vitreous was present in the AC. So after 1 month without AGM, vision was 6.6, AT was 10 millimeter mercury. So just one case is rare case was reported, which causes the, after 10 hours, patient reported back with the severe headache, right-sided periorbital pain and profound dimness of vision. They did the ND YAG laser, now patient is fine. So YAG capsulotomy done beyond the IOL margin could be the region for vitreous to move anteriorly through the pupil and block the pupil. So it is recommended to perform a smaller capsulotomy within the anterior capsular rim with minimal energy. Anterior segment optical coherence tomography is an effective imaging tool for diagnosing and confirming the presence of vitreous in the anterior chamber and monitoring its status during the treatment. Thank you.
Thank you, Dr. Kajal. You have clearly emphasized the importance of YAC-PI in all these cases. YAC-PI definitely helps, and you have nicely described the mechanism why it occurred, especially the thing. And the vitreous blob that you demonstrated in the pupillary margin was very nice, and that's it. Like, there is no other thing that you could have done, and you have handled the
Only
cases
PI
well.
can
Yeah,
solve the prevention of the glaucoma,
yes,
prevention of the
yes.
glaucoma.
You have clearly emphasized the need for PI in all these cases. Thank you.
Thank you, sir.
Yeah. Dr. Piali Mondal? Yeah, please come. A rare case of iridocorneal endothelial syndrome managed by MF glaucoma valve implantation. वहाँ उधर चले जाओ.
Good morning, everyone. I'm Dr. Piali Mandal. A 45-year-old female presented with sudden onset pain and dimness of vision in right eye for 2 weeks, referred from Peripheral District Hospital. Dimness of vision in right eye for past 1 year, with sudden onset pain and deterioration of vision over 2 weeks. No complaint in the left eye. The past history, nothing was significant. In treatment history, the patient was on eye drop timolol, travoprost, dorzolamide, and ripasudil. Systemic examination, everything was within normal limit. On ocular examination, the visual acuity of right eye was 6/60, left eye was 6/6. In right eye, there was pupil polychoria, lid and agnexa was within normal limit. Conjunctiva was clear, cornea was edematous, as we can see in the picture. Iris was atrophied in the right eye, but within normal limit in left eye. Lens was clear. Fundus was, cup disc ratio was 0.8, while in the left eye, the cup disc ratio was 0.3. On IOP measurement, right eye was 28 mmHg, and in left eye, it was normal 16 mmHg. Gonioscopy, there was peripheral anterior synechia in all quadrants, but in left eye, there was open angle in all quadrants. On OCT RNFL examination, the right eye showed thinning of inferior neuroretinal rim. In left eye, there was no thinning revealed. Perimetry examination showed the right eye had a visual field defect. On specular microscopy, there was reduced endothelial count, high pleomorphism, polymegathism, loss of typical hexagonal shape of cells. The patient was diagnosed as a case of iridocorneal endothelial syndrome. The patient was admitted and started on intravenous mannitol infusion after completing the baseline investigations, that is FPS, PBBS, urea creatinine, and cardio fitness. The patient was planned for MF glaucoma valve implantation surgery. Post-operative management, on post-op day 1, the visual acuity of right eye was 6/60. The IOP was slightly lowered to 22 mmHg. The patient was given on topical and oral antibiotics, cycloplegic, topical and oral steroids. On post-op day 1, the visual acuity of right eye was 6/60, and the IOP became even more lowered to 18 mmHg. Thank you.
Yeah, thank you, Dr. Piali. Like, could you have managed the case in a different way? Like I saw the case that tube was in the anterior chamber. Was the chamber depth sufficient?
So when the patient first presented to us, that time the patient only had blurring of vision. So that time we managed the patient with only medical management. But after 2 to 3 weeks, the patient again presented to us with, and in the first visit, we did all the investigations. But after 2 to 3 weeks, the patient again presented with the deterioration of vision and mild pain. So at that time, we thought that implantation surgery would be the best one.
No, like what was the scope of iridocorneal adhesions? Was it 360 degrees or was it?
So it was around 3 quadrants total, not total 360.
Yeah, what I want to ask is, I saw the tube in the anterior chamber. Was the depth sufficient for the tube to be placed in the anterior chamber? uh, is there not a risk of that? I saw the tube a little bit long also, touching the endothelium and causing corneal issues later on.
But that thing we could not find in
the
the subsequent
depth was
visits. The
reasonable.
depth was within
Okay,
normal. It was
okay.
sufficient.
Okay, okay. Thank you. Thank you.
Thank you, sir.
A nice presentation.
Thank you, sir.
Dr. Narendra Rajak. Okay. With yeah? Prachi. Okay. Dr. Prachi Grover. Okay. AGV in a failed trap.
Yeah.
Yeah.
Good morning, everyone. So I'll be discussing a case. So here's a patient. He was referred to me for the glaucoma surgery. So my half job was done for counseling the patient. So he was a 32-year-old male with a both eye advanced glaucoma. For last 1 month, he was on maximum medical therapy. With the advanced glaucoma on field OCT, he had defects also. So considering his age, so I planned him for a trap surgery. So initially his trap was performed. Sorry, my video is not running. So routine trap was done. So in both the eyes, left eye trap, sorry. Left eye trap was okay, working well, but the right eye trap was like, it got failed. After 3 months, pressures were high. Instead of starting him on again maximum medical therapy, but pressure came down to 20, which was still high for his fields and his cupping. So I planned him for AGV. So in the superior temporal quadrant,
Good morning.
pocket was made, AGV was inserted, then tube was inserted, and after scleral patch, the eye was closed. So on day 1, pressures came down to 10, bleb was well formed, tube was in C2, AC was quiet, but on day 30, tube was exposed. So topical steroids, oral doxycycline was started, and then I used amniotic membrane. Then again the pressures were under control, bleb was formed with a stable visual field. So this was his last follow-up. I'm following this patient since last 5 years. So he's working well. So here are my few pearls. Priming the valve with BSS is important, and avoid grasping the valve plate above the silicone sheet. Bevel should be created facing upwards while inserting into the anterior chamber. Proper placement of the tube is crucial for better long-term outcomes. So AGV is an effective option in failed filtration surgery. Tube exposure is a potential vision threatening complication of GDD. Treat exposed tube immediately and aggressively. Thank you.
Yes, Dr. Prachi, you managed the case well with the AGV, but I saw the video that didn't play, the post-operative. The bleb looked a bit cystic. Did you try needling before you?
Yes, sir. I tried needling.
Okay, the needling was not successful.
Yes, needling was.
Okay.
Yes, sir.
Okay. Anything? Huh?
Okay,
Thank you.
sir.
Thank you. So, Dr. Jyoti Rani Acharya, are you here? Or we mark you absent now? Dr. Narendra Rajak? No? Dr. Shivam Gupta? Dr. Shivam will be speaking on a novel technique of post-traumatic cyclodialysis cleft repair by direct cycloplexy with Sioni ring.
Good morning to all. I hope I'm audible. So we are going to discuss a case of novel technique of post-traumatic cyclodialysis repair by direct cycloplexy with Sioni ring. So here is a patient, a 27-year-old female who was sitting below a coconut tree, and the coconut fall on her left eye, and she came to us with with the left eye appearing like a traumatic cataract. Her vision was 6/12, intraocular pressure being 18. We did a gentle gonio, and we could see occludable angles in the gonioscopy and anterior subluxation of lens and cataractus changes. There was a traumatic mydriasis present. So patient was underwent left eye phacoemulsification with acrylic lens, and a capsular tension ring was implanted in the bag. So post-op day 1 was uneventful, 6/24 vision, IOP 18, and PCIL was stable. But when we asked for a second follow-up, patient came with 3 millimeter pressure, PCIL was stable, but there was a traumatic mydriasis, and there were certain new changes that optic disc edema was there, and some ILM folds could be seen. So so we could see some cystic ILM folds and choroidal folds extending to from optic disc were seen. So what was this can be a diagnosis of post-traumatic cyclodialysis cleft with hypertonic maculopathy. So we did an OCT macula of it, which showed abnormal foveal contour, fluid accumulation interretinally with choroidal undulation suggestive of hypertonic maculopathy. So what is the reason for this? So let's do gonioscopy, what we might have missed. So in gonioscopy, because of the hypertonous nature of the globe, it was not well visible, but yes, we had to go ahead, we did a UBM, and here we could see a cyclodialysis cleft there. So to correct localization, we used an AIOCMT3 KCR2 to localize the cyclodialysis cleft, and it was appeared to be from 7 o'clock to 9 o'clock over here. So we went ahead and started on cyclodialysis diagnosis was confirmed. The patient was started on topical steroids. It didn't improve. Then we started still remained low, so we started oral steroids. After 6 weeks of initiating conservative therapy, it was not working. Then we started with cryotherapy was done, direct cryotherapy was done, but IAP was still 4 mmHg within the follow-up period. Now what to do? Now we have only to go ahead with surgical plan. So why not there were multiple surgical plans we could go on, like indirect, direct, or multiple options. So why not we planned a CONE ring implantation. So here we implanted a double ring CONE ring inside the sulcus. So yes, we achieved full success with it, with IAP coming back to 16 mmHg and anterior chamber well formed with and here after 2 months follow-up, patient had good 15 mmHg pressure, normal depth, PCL, and resolving optic disc edema. And so here we can see gonioscopy, nasal side, the area we were localizing, the cyclodialysis had appeared to be normal. Now the fundus is also looking normal. If you look at serial OCTs taken from September 23 to 1st March 24 after surgery, and recently taken yesterday only one scan was taken, you can see it has improved. So here was a KCR2 image before and after the procedure, and here you can see a cyclodialysis inside the cleft, and it's a angle 360 degree, and if you see this video, all 360 degrees, the cyclodialysis have been repaired. So what is cyclodialysis? We all know separation of longitudinal fibers from ligament cell spur. So what are the multiple options? It can be traumatic or iatrogenic, and so we can have ab external approaches, and here we have ab internal approaches of single suture, and like what is special of our technique, we would a double CONE ring, which has a 2 run, one will give the endocyclotamponade, and other ring will give a direct cycloplexy effect, pressuring the cyclodialysis cleft. The limitation of our procedure being, there are high chances of ciliary body erosion, hemorrhage, pain, and inflammation, and longer operative time because it's a new procedure, and inadequate sulcus support can be there, and there is also the learning curve for that. Thank you.
Very nicely managed. That means you have to do, in traumatic cataracts, you should do a gonioscopy compulsorily. And secondly, was there any zonular dialysis along with this?
Sir?
Was there any zonular dialysis?
Sir, actually, during, it was some anterior subluxation of lens was already there, sir. And yeah, you're very right, sir. We should have done a AIOCMT pre-hand also, or at least an UBM beforehand. Second thing, while doing the phacoemulsification only, due to the anterior subluxation of lens, we placed the CTR inside the bag.
Okay. Thank you.
Thank you, sir. Thank you.
Dr. Vishakha Shangivar. Dr. Vishakha shall be speaking on the diagnosis of tuberculum cellular meningioma confounded by glaucoma.
Good morning, everyone. A 66-year-old female patient, homemaker by occupation, came to the OPD for refraction and routine glaucoma follow-up. On clinical examination in right eye, best corrected visual acuity was 6.9 and 6, anterior segment within normal limits with grade 2 nuclear sclerosis. Intraocular pressure was 15 millimeters of mercury on Goldmann applanation tonometry at 10 a.m. Fundus examination showed normal size disc with 0.3 vertical cup disc ratio. Foveal reflex was present and periphery within normal limits. In left eye, best corrected visual acuity was counting finger half meters, n less than 36, RAPD was present with grade 2 nuclear sclerosis and intraocular pressure was 14 millimeters of mercury on Goldmann applanation tonometry at 10 am. Fundus examination showed normal size disc with disc pallor and 0.3 vertical cup disc ratio. Foveal reflex was present and periphery within normal limits. Previous systemic history showed patient was hypertensive since 10 years and history of carcinoma breast, for which she was operated and received chemo in 2016. Patient was diagnosed to have primary angle closure glaucoma in 2019 at routine ophthalmic checkup. Both eye laser PI was done and she was started on anti-glaucoma medications for optimal IOP control. Perimetry was normal at that time and left eye OCT RNFL showed a superiotemporal wedge defect. This is the OCT RNFL of the left eye in 2019. A regular follow-up was advised but patient didn't report till 2022 because of pandemic. In 2022, she complained mild reduction in left eye vision with right eye best corrected visual acuity 6.9 and 6 and left eye 6.18 and 6 with intraocular pressure 14 in both eyes. Significant pallor noted in left eye with defective color vision. Left eye AION was suspected. She was advised a physician review and follow-up perimetry, but she did not report. Patient next reported in 2024 with further diminution of vision in left eye. In right eye, best corrected visual acuity was 6.9 and 6, and in left eye, counting finger half meters, n less than 36 with left eye RAPD. Dilated fundus examination of left eye showed significant pallor with minimal cupping, and right eye showed minimal pallor. Perimetry of right eye showed depressed areas in nasal hemifield, and OCT revealed widening and deepening of the RNFL loss in left eye. Right eye remained normal. In view of significant pallor, RAPD, and progressive loss of vision in absence of any other documented fundus pathology, MRI orbit and brain was advised. MRI brain showed large tuberculum celli meningioma with clinoidal attachments. Conclusion: concomitant neurological pathology should be suspected when there is disparity between disc changes, visual acuity, and visual field loss, especially when associated with RAPD and color vision defect, after ruling out confounding ocular lesions. Thank you.
Yes, that was a nicely documented case, Dr. Vishakha. It's always important, especially in the cases of bilateral temporal pallor. If you see the way, in your clinics, always such patients should be subjected to Humphrey perimetry. You will not be surprised, many times they end up with getting hemianopias and other neurological deficits. So it's a very important sign. You should never ignore bilateral temporal pallor also. This case specifically, you demonstrated in one case this thing, but any specific pallor like glaucoma, the presentation is somewhat different. There is cupping, there is focal defects, there is notching, everything, but the rim remaining normal, but only the presence of pallor. You should always subject these cases to MRI. Okay? Thank you. Well done. Yeah. Satyabrata Tripathi.
Yeah, is Satyabrata Tripathi here?
Yeah, please come.
Please. He'll be talking on Chandler's syndrome, a case report.
Good morning, everyone. Myself, Dr. Satyabrata Tripathi, first year postgraduate resident of Dhir Hospital and Postgraduate Institute of Ophthalmology. Today, I am going to present a case report of 37-year-old female. Came to our hospital with complaint of diminution of vision in right eye since 2 months, associated with photophobia and color halos. She was apparently all right 2 months back when she started having diminution of vision in right eye, which was insidious in onset with dilating pain and gradually progressive. She was a known case of angle closure glaucoma, diagnosed somewhere else. When she came to us, she was on 3 anti-glaucoma medicine. On examination, her right eye unaided vision was 6/24, which was correcting to with pinhole 6/12, and left eye vision was 6/6. On applanation tonometry, right eye intraocular pressure was 40 mm Hg. On slit lamp examination, right eye conjunctiva was mildly congested and cornea was little lusterless, and anterior chamber was von Erich's grade 2. On pupillary examination, correctopia was present, we can see in this photograph, and but pupil was reactive. And in left eye anterior segment examination was within normal limit. On fundus examination, right eye optic disc was medium size, vertically oval with bipolar notch with cup disc ratio 0.9:1, but foveal reflex was healthy, and left eye fundus examination within normal limit. In gonioscopy, right eye, we can see in all four quadrants zero structure was visible, and with presence of pus, like here we can see the broad tented pus. In specular microscopy, which is an important diagnostic tool to diagnose eye syndrome, if we compare right eye with left eye, we can see the presence of eye cells, which is typically abnormal, rounded, large, pleomorphic, with centrally white, peripherally black, with white intracellular margin, like I mentioned in this picture. And if we see the cell density also decreased in right eye, CV ratio increased, and hexagonality also decreased. In anterior segment dosity, we can see the migration of abnormal corneal endothelium over the anterior surface of iris as well as angle. And in visual field analysis in right eye 30-2, we can see there is biarcuate scotoma, which is correlating with optic disc finding. And in 10-2, we can see the central fixation is not involved. So on the basis of clinical findings and investigation, we diagnosed this case as a Chandler's syndrome, which is a subtype of eye syndrome. And primarily we managed with therapeutically, but after maximum use of anti-glaucoma medicine when IOP is not controlled, that time we planned for surgery. So according to many articles, we found that the GDD has long-term success rate better. So that's why we planned GDT in our case. And we took Ahmed glaucoma valve as a GDT. And after implanting Ahmed glaucoma valve, we can see the day 1 post-op follow-up, the intraocular pressure in right eye is significantly decreased. But in end of second week, we can see the intraocular pressure increased. It's suggesting of hypertensive phase after implanting Ahmed glaucoma valve. But we managed with 3 anti-glaucoma medicine. And end of third month, we can see the IOP is well controlled. Then we shifted 1 anti-glaucoma medicine. And in end of 6 months, we can see the IOP is well controlled with 1 anti-glaucoma medicine. So when IOP is not controlled with the medical therapy in eye syndrome, surgical treatment is a good option to decrease the IOP and decrease the dependence on anti-glaucoma medicine. And however, predicting long-term success rate with surgical procedure can be difficult because the migratory abnormal endothelium can block the tube, and other complications like corneal decompensation can cause. Thank you.
So, thank you, Dr. Satyabrata. That was a nice documentation, and you managed the case in the required way. So, is Dr. Srilikita Goli here? Yeah. She will be presenting Cogan-Rees syndrome case report.
Good morning to everyone. Today I am going to discuss about Cogan-Rees syndrome.
Please go slow, yeah? Please go, we have a lot of time. Actually, they have given us only 11 cases in each 4 minutes, so they have given 75-minute session. So you can take your time.
Okay.
Yeah, please explain everything, be peaceful.
Cogan-Rees syndrome is a type of ICE syndrome, which is a progressive clinical spectrum of corneal endothelial abnormalities, which is affecting the cornea, iris, and iridocorneal angle. There are 3 clinical variations which are recognized. Those are essential iris atrophy, Chandler syndrome, and Cogan-Rees syndrome. It is often associated with secondary glaucoma, which is due to obstruction of trabecular meshwork in the iridocorneal angle, the formation of peripheral anterior synechiae, or both can happen. Vision loss is typically due to progression of secondary glaucoma and corneal decompensation. Here is my case of 20-year-old female patient who noticed an abnormal appearance of pupil in her left eye, which is enlarged and shifted downward, and it is gradually progressive since 5 years. And she also noticed diminution of vision for distance since 5 years, which is insidious in onset and gradually progressive. She has no other complaints of pain, redness, watering, photophobia, trauma, or other laser procedures to her eye, intraocular surgery, and similar appearance in the other eye. Coming to the ocular examination, her vision was 6/6 in both eyes with a refraction of minus 0.5 diopter spherical in right eye and minus 0.5 diopter spherical and minus 0.25 diopter cylindrical in her left eye. And NCT is normal and CCT is somewhat towards the lower side. Pupils are, left eye pupil is displaced downwards, which is mid-dilated and irregular. Pupillary reaction, it is sluggish in the left eye. Ocular movements are full and free in all gazes. Coming to the slit lamp examination, right eye is normal. Left eye anterior chamber is shallow, mainly at the peripheries, with iridocorneal touch, which is present from 1 o'clock to 2 o'clock and from 7 o'clock to 9 o'clock. Pupil is inferiorly displaced and full thickness iris hole is present at 2 o'clock, which is surrounded by iris atrophy. And iris atrophy is present at 1 o'clock. And this is the magnified view of the iris, which is showing loss of normal iris pattern and with ectropia on uvea from 2 o'clock to 11 o'clock, and multiple pigmented pedunculated nodules are present superior-nasally and inferior-temporally. Gonioscopy shows peripheral anterior synechiae in 2 quadrants. Coming to the fundus examination is normal with normal CD ratio, and perimetry is normal. And ONH and RNFL analysis shows no thinning, and which is normal. And ASOCT shows multiple anterior pedunculated iris nodules with underlying stromal thinning and iris adhesion to the corneal endothelium. My provisional diagnosis is left eye Cogan-Rees syndrome with primary angle closure, and differential diagnosis for this multiple pigmented iris nodules include Lisch nodules, diffuse malignant melanoma, iris mammillomatosis of oculodermal melanocytosis, inflammatory nodules associated with granulomatous uveitis, metastatic seedlings. Management, we have done an angle closure provocative test in which we have, there is no increase in IOP. So we have kept patient for regular follow-up for every 3 months, and we have given her glasses. Discussion. Cogan-Rees syndrome is popularly called as Innes reverse syndrome, present with a myriad of manifestations such as peripheral anterior synechiae, loss of iris crypts, fine iris nodules, ectropia on uvea, irregular pupil counter, and corneal edema and iridocorneal angle abnormalities, and secondary glaucoma. The characteristic iris nodules arises due to pinching of iris stroma by the overlying aberrant translucent endothelial membrane. Multiple delayed peripheral anterior synechiae extend in all directions and may block the angle of anterior chamber. It is believed that glaucoma is caused by the proliferation of corneal endothelium with the formation of a membrane that progressively covers the trabecular meshwork, and not due to the gonial synechiae that emerged lately. The present case has loss of normal iris pattern, iris atrophy present at 1 o'clock position, ectropia on uvea is present from 2 to 11 o'clock position, multiple pigmented pedunculated nodules are present superior nasally and inferior temporally. Medical management, there is no therapy available which targets the pathogenesis of ICE syndrome. Topical anti-glaucoma medications are usually the first line of treatment for raised IOP, which is not seen in my case. And hypertonic saline is used to reduce the corneal edema. Surgical management includes, if there is a glaucoma, trabeculectomy can be done with antifibrotics and drainage devices. And maintaining long-term success is challenging, as fistula and trabecular meshwork can be obstructed with advancing abnormal endothelial cells. Cornea, in advanced cases, if there is a corneal edema, we can manage with penetrating keratoplasty, DSAC and DMAC. Conclusion, to conclude, Cogan-Rees syndrome presents with myriad of iris manifestation and features of glaucoma with unclear pathogenesis. The present case features the occurrence of characteristic iris nodules along with ectropia on uvea and peripheral anterior synechiae. These are my references. Thank you.
Thank you, Dr. Likita. It was a nice presentation. So for the audience, like we saw subsequently a case of Chandler syndrome with the endothelial growth requiring intervention, and that was managed well with the AGV. And in this case, since all the parameters were within normal limits, the patient was under observation. So, and Dr. Likita nicely discussed the differential diagnosis about different forms of iris nodules, and thank you. It was a nice presentation.
Is Dr. Aditya Sharma here?
Last. Vinod Kumar. Vinod Kumar. So Vinod Kumar is also not here. Okay, we have to conclude the 11, four speakers are not able. Anybody final call for Dr. Jyoti Rani Acharya? Not here. Dr. Narendra Rajak? Aditya? Vinod? Okay, in that case, we conclude the session. It was a nice potpourri of case selections in glaucoma. I thank all the speakers for their participation. Thank you very much.
Thank you.
Acha, yeah, please come, please come.